Hi everyone, and this is Group 9-ish and our project on the Ossicles. So, hope you enjoy the presentation. So, first of all, we're going to start off with the borders of the middle of the cavity, in which the ossicles lie. And I want to draw particular attention to just three structures mainly, which is the tensor tympani, which arises from the anterior wall and then projects forward. Because in this model, you're looking as if you are the tympanic membrane, essentially. So, that comes forward and will project here, which will gain significance later on in the presentation. And this muscle here, which is it's labelled as the pyramidal eminence, but it encompasses the stapedius muscle, which comes out that way, which is sort of like at this sort of area. So that also has significance. And the last structure I'd like to highlight is the oval window, which will also have significance later on. So the ossicles, they are a pivot system, basically, of synovial joints encompassing three bones. Their function, apart from impedance matching, which we've had a beautiful explanation of, is to transduce the sound vibrations from the tympanic membrane to the labyrinthine wall at the oval window. So the kinetic energy from the membrane vibrating is then transduced to electrical energy. So if you think about it, it's sound energy, vibrational energy, or kinetic energy through the bones, and then electrical energy. And then that electrical energy is interpreted in the brain as sound. So here is our wonderful middle ear and the ossicles with it. And first of all, I would like to start with the Malleus, which I actually have props to help out with. Courtesy of Asda's best pans, we have our Malleus. So the handle is enveloped in a tympanic membrane, and its upper part is what attaches to the tensor tympani. Its posterior, so if we think of this, the posterior head, because it has a head and a neck of Malleus, is where it articulates with the incus, so it has a layer of hyaline cartilage as a synovial joint. And unfortunately, pans don't have little bits like poking out of them, but if you think it will have two lateral processes here and one anterior process, and these are linked to ligaments which tether it to the lateral processes will be tether it to the walls either side, and the anterior process to the anterior wall. So it is suspended in the cavity. Do you hold that for a sec?
Yeah, okay.
Thanks. So then we get to the incus. To give the incus, nothing looks like an incus, so I had to make one up. It's comprised of three main parts, which is, just bear with me because that is meant to look a little bit more horizontal, but nothing looks like an incus. So the body, which articulates with the Malleus at its posterior end, so it would probably be something like that. It has a short process, It has a short process which goes off that way, and a longer process which projects medially in parallel to the Malleus. This then has, as it projects medially, it will articulate with the Stapes. And it is also suspended by ligaments into the cavity. So here is the Stapes. And it has a small has a small hole which is round. It's one of its ends, which will articulate with the incus. It bifurcates at its neck to a anterior and posterior process, and then goes to the base of the stapes, which fits inside the oval window. Stapedius will insert on the posterior side of the neck. And I will now talk about both those muscles which I've talked about. Oops. So tensor tympani originates from the cartilaginous part of the eustachian tube, and it loops round and then comes forward as if like back to that further diagram where you are the tympanic membrane, so it's forward, and it will go into the hanger malleus. This is innervated by the mandibular nerve, and when it contracts, it deviates the malleus medially, which stops like hyperpercussion, but like it stops the loud noises being too damaging, because it tenses the tympanic membrane when there's a loud noise. So then there's Stapes, which originates the pyramidal eminence, inserts into the posterior neck of the stapes, innervated by the facial nerve, and when this contracts due to a loud stimulus in like the stapes reflex, it prevents excessive percussion of the inner ear, and by pulling the stapes posteriorly. I will now hand you over to Tom, who's going to talk about otosclerosis.
Okay, so when we're looking at the ossicular chain clinically, the thing that comes to mind is otosclerosis. It's a reasonably common condition in the UK, and as you can see from the slides, it's a remodelling of the stapes footplate, restricting its ability to transmit sound from the incus to the oval window of the cochlea, where it would be then converted into the sound that's processed by our brains. So it's an example of conductive hearing loss. In the later stages of the disease, you may develop sensory neural hearing loss, as you get damage to the nerves in the bony shell of the cochlea. The patient will present with hearing loss, sometimes with tinnitus, and more rarely vertigo to areas. So here we have a picture showing that outgrowth of the footplate there, which is restricting the movement of the stapes against the oval window. Epidemiology, I've just said it's fairly common, particularly if you are a white or Asian young pregnant woman. So that's your epidemiology. Why do people get it? The causes. It appears to be a dual causality. More recently, we've come to think that you need a viral infection combined with a genetic predisposition in order to actually start the development of this condition. And there's two stages in the development of it. First is the active stage, where we get the breakdown of the pre-existing lamellar bone that you'd find in a normal healthy stapes, which moves on to mature stage, where you get the deposition of the spongy bone, which restricts the movement of the stapes, giving the clinical presentation. Some symptoms were said. Paracusis we haven't. That describes the phenomenon whereby if there's more background noise, the patient is able to discern people's voices more easily, discriminating them. And tinnitus and hearing loss, as I've said, fairly generic symptoms, which makes it hard when you come to diagnosis, because you then have a lot of differential diagnoses to rule out. Includes acute otitis media, cholesteatoma, fracture, dislocation of the ossicles, and other growths or obstructions of the movement of the ossicles within the inner ear. The gold standard for diagnosis is when we look at an audiogram, we get a Cahart notch, which is a drop in bone conduction at thresholds of 20 to 30 decibels, most pronounced at 2000 hertz. Two treatment options, hearing aid or surgery. The more temporary of the two is hearing aids, which are small battery powered devices fitted behind the ear or in the external opening of the ear canal. This is by no means a permanent solution. It's only there to overcome the loss in conduction, but it's preferred for people who are very elderly with only minor hearing impairment or do not wish to undergo the surgery. The surgery itself is corrective in most cases, comes with a risk of hearing loss as well as damage to some of the nerves surrounding middle ear, including the facial nerve, so you may get facial nerve palsy. We use a CO2 laser to remove the majority of the stapes, leaving only the foot plate. It has to be a CO2 laser so as not to cause overheating of the surrounding structures. And here we go, this is a nice picture we found showing the steps, and we get a piston prosthesis here we can see, which we attach at one end to the incus, and at the other end goes through the hole that we've drilled in the foot plate of the stapes, and this will allow transmission of the kinetic energy from the incus through the oval window to the cochlea, where the process should then carry on as normal. So that's all we've got for you. Thank you. Is there any questions?